All right, maybe let's go ahead and get started. Hi, everyone. My name is Ria. I'm going to be the moderator. Um, we are very excited here today to have our session with ACRO and ROVER on non-cancer indications for radiation. I think this should be a really interesting talk. And we're very lucky to have three esteemed attendings here today talking about various non-cancer indications for radiation. So I was just going to give them a chance to go ahead and introduce themselves, maybe starting with Dr. Parikh.
Hi, I'm Simil Parikh. I am a radiation oncologist out of Port Huron, Michigan at Lake Huron Medical Center. And I am a huge fan of radiation for benign indications.
Thanks, Dr. Parikh. And then is Dr. Schuster on to introduce herself?
I am. I'm Jessica Schuster. I am in Madison, Wisconsin. I have a joint appointment with the Middleton Veteran Affairs Hospital and also with the University of Wisconsin, and serve as our department's associate program director, and really looking forward to hearing some additional indications. And full disclosure, I'm interested particularly in Dr. Parikh's talk because I think the VA is an excellent place to potentially do therapy for benign indications. But I'll be chatting about fibromatosis, Dupuytren's, and Ledderhose.
Awesome. We're very excited. And then Dr. Flickinger is going to be logging on just a few minutes late. So we'll go ahead and get started. I'm the moderator. I don't need my own slide, but I guess we'll get started with Dr. Parikh's case. To the audience members, if you guys have any questions to ask, please type them in the chat. And make sure that when you do that, you're saying reply all, not just replying to the host, so that everyone can see the question. And then there might be one or two poll questions if there's any kind of interactive questions from the speakers. And with that, let's get started with Dr. Parikh's case. He'll be talking about osteoarthritis and plantar fasciitis.
Okay, so this is a little different than cancer medicine in the way that these are not challenging cases or difficult cases to go through when you see them as a doc. I will go through a case. Actually, I was hoping to have a video because I recorded a couple days ago with a patient. I had a 63-year-old lady who in the past had been a runner. She was in good health, but she had very achy knees. And she had seen our ad for low dose radiation therapy for arthritis. So she made an appointment. She came to see me. She's generally very healthy. She had no history of inflammatory arthritis. She'd been told by her primary care doctor that her pain in her knees and her stiffness was due to arthritis. And she had plain film showing degenerative joint disease. So I talked to her about the treatment options for this, which we know that you can take NSAIDs, you can do physical therapy, you can talk to a surgeon about surgery. The main indication for surgery is pain, and then we talked about what we can offer at our center. The patient wasn't interested in surgery. She had already been through lots of physical therapy, and so she was not super excited about doing more of that. So she wanted to hear more about low dose radiation. And I talked to her about it, and I'm going to tell you guys more details, but she elected to proceed with it. She finished her course of treatment. By the end of treatment, she was already having a relief. She came in 2 weeks later and said, "Doc, I've run for the first time in a couple of years." She called her mom, who also had achy knees. Her mom came in to see me, and we went through the same discussion, and we treated her knees. They both came to see me this Wednesday, and the week prior, her mother, the patient's mother, who was very not bedbound or not ambulatory, but definitely not active, went to New Mexico with the family and went on a hike for the first time in a decade. Now, whether this is a low dose radiation or whether it's some placebo effect, and I'll get into that in a sec. It's unclear. What I'm seeing, I've treated about 80 patients, and about 2/3 of them have had responses to treatment. Positive responses. I've had people get off opioids that they've been on for 3 years. I've had patients now start to exercise and lose weight. They, in general, feel better. And so this is very different than what we do. This is all about how you feel. This is about wellness. This is about pain management, about quality of life. And so we approach this a lot differently than we do radiation for oncologic indications for a variety of reasons. But I look at it very differently. It's energized my career. It's stabilized our practice volumes, and I've brought great benefit to many patients. This is an easy, effective treatment, and it's worthwhile. So low-dose radiation therapy is not new. It's been used for decades and decades. It's been used in Europe for a long time. In Germany, particularly, they do arthritis radiation all the time. Plantar fasciitis, same thing, different dose we use, but we've been treating plantar fasciitis. It's a similar phenomenon with inflammation at the bottom of the foot, bone spurs, and in the heel. We have this discussion about low volumes at centers. Well, there's 32 million patients with osteoarthritis. There's 2 million with plantar fasciitis. The number of patients that get radiation for oncologic indications is about 1.5 or 1.8 million or something like that. Whatever the number is, it's much lower than the combined patients with OA and plantar fasciitis. So this gives us the opportunity to help people. And we can go to the next slide. So who do we treat? Patients with mild to moderate disease seem to do the best. You know, someone who's basically bedbound does not seem to have great results with this treatment. Based on the literature, the hands seem to have the best outcomes. That was who we treated. We treat a lot of hands first because the literature showed a very high response rate, no toxicity at all. After talking to friends, Bobby Conner, who's in Illinois, Todd Scarborough, who's down south in Tennessee, who have a lot of experience treating osteoarthritis, they noted that they didn't see any differential outcome based on what joint was treated. And so we treat everything, hands, knees, back, hips, with good results. What we need is a confirmed diagnosis of OA, or we order some plain films to see joint-space disease. Plantar fasciitis is a clinical diagnosis. They already have it before they come to you. And if you're seeing them without a diagnosis, you can diagnose it yourself. It's essentially tenderness along the foot with palpation and then activity, pain with activity. Go to the next slide. So why would this work? Well, you know, I'm not going to get into the basic science of it because honestly, we don't know. We have some thoughts on why this is working, but it's above the scope of this discussion, and we're still kind of figuring it out. My guess is some sort of anti-inflammatory effect and some change in the microenvironment in the joint space. The data is not that strong for both, but the plantar fasciitis data is a little bit better. There's two studies. There's no, I'm not going to get into details of the studies. It's more a qualitative talk. One study compared 6 gray to 0.6 gray. And the reason they did 0.6 gray is because if you do a control arm and they don't lie on the table, you don't really have a good control arm to compare it to the actual treatment dose. So they do 0.1 a day in 6 fractions for the sham, and then 1 gray every other day for the treatment. And that study showed a way better benefit with 6 gray versus 0.6 gray. There's also been a 3 gray versus 6 gray study, and the 3 gray was found to be effective, just as effective as 6 gray. Most of the literature uses 6 gray in 6 fractions, and so we use a little bit of a modification of that, and I'll get to that. There's another study for plantar fasciitis showing better pain control compared to steroid injections. Steroid injections, the data is very weak. It's very weak for osteoarthritis as well. And you can't blind it, but it appeared to do better than steroid injections for plantar fasciitis. The OA data is outcomes rather than studies mostly. There's one negative trial. It's a Dutch study. It looked at the dose. We used 3 gray and 6 fractions every other day. Oh, I'm sorry. They did 6 gray and 6 fractions, not 3 gray and 6 fractions. So the dose was different than what the Germans have been using. Biologically, they found that the effect seems to be in the 0.3 to 0.7 gray per day range. And because of that, I don't know why they selected 1 gray per day. They also didn't do retreatment. So about 10 to 12 weeks after treatment, the German physicians offer a retreatment if they didn't get a full effect or any effect at all. and it's the same dose repeated. And that was not in the study. It's also about 50 or 60 patients versus 30 or 40,000 treated in Germany. And sometimes, we radiation oncologists are very stuck on trials, and it wasn't in the study the exact same way, and you can't treat them that way. And the fact is, we they have seen that it works. They're seeing it with their eyes, and how it's working, it's not really explained. But again, if you're getting people off of opioids, if you're getting them to exercise, even if it's a sugar pill, that's probably a good thing. That study, I don't really hold it in high regard. And it's always brought up to me as the negative study, and I just, I give my critique of it. There is an open, I believe it's going to be open soon, a study with the more German style of treatment that I believe is housed at Vanderbilt with Austin Dove and friends. And I think that's going to give us a lot more insight. Next slide, please. Okay, how do we do it? Technique and billing. As simple as possible. Okay, this is 3 gray and 6 fractions. It's funny when I tell people about this and they start treating, they call, they're doing these complicated plans, complicated setups. Guys, it's 3 gray and 6 fractions. 25 gray a day. It's not, there's no toxicity. There's 0% toxicity. For knees, I do APPA. For back, APPA, neck, hip, those are well suited for APPA. We do a CT stim. You could do it without a CT stim. But we don't do that in most things with radiation oncology these days, unless it's like an electron setup. For hands, I do a direct electron field, no CT. We just not only do the measurements, clinical setup on the table. You can do it other ways. There's people that do APPA, there's people that do AP photon field, there's people that do nail shielding. We've treated a lot of patients. 3 gray and 6 fractions is not going to hurt your nail bad. For feet, we do opposed laterals. It's logical, do it the way that makes sense to you. I think of it like a bone mat. We don't bill it as 3D, we bill it as isodose complex. And I would suggest doing it that way. This is not a hard treatment. This is not a volumetric treatment. There's no OARs. This is a very simple treatment. It should be cost effective for your center, and it should be cost effective for the patient. They shouldn't get a high copay because he did some fancy technique. Do not do IGRT. You do not need to do IGRT. This is going to get us in trouble. Like, this is not necessary to do. It's not going to change the outcome. It's not a tight field. There's no volume, again, that we're looking at. Do not do IGRT. If you're a nervous person, do a port film every day. Don't charge for it. What I do for my planning is I contour the joint space itself, and then adjacent tissue. If it's the knee, I palpate the knee and see how it feels, where it hurts, and include that much of the tibia, fibia, the femur and the tibia and fibula as much as needed based on their pain. I make a volume out of that. I allow max dose of 120, 125%, because I don't want any complex planning or putting on extra fields or anything like that. If you do 125% of 50 centigrade, we're talking 0.625 gray. Again, it's in the range of effective treatment for arthritis. And so that's what we do, and we cover it at 95 to 95. You could also treat you can treat the isocenter. You could treat 100% coverage. Like this is not an exact science. Use logic and use your residency training to kind of guide you for that. The dose I use for OA is 3 gray and 6 fractions every other day. And then for plantar fasciitis, the literature says you can use 3, you can use 6 and 6. I've talked to colleagues and they've done 0.7 and 8 fractions, 5.6 gray. And that's worked better for me. So I've kind of moved on to that, although that's not in the literature. The payers are happy to pay for this. This is an indication. This is listed in Evicore's indications for radiation. This is not anything considered experimental by payers or the government. I've not had any trouble. Every patient we've collected them. It's not an insurance issue. This is completely okay by them. So how do you get patients? My starting way to do it is seeing breast follow-ups who are complaining about achy knees or achy hands, achy feet. They've already had radiation. They're not scared of it necessarily. You tell them it's going to be way easier than last time. It's only going to be 6 treatments instead of 30 or whatever the number, 16 treatments, and they're not going to get any side effects. We did TV ads. We did radio ads. That didn't have much confidence in radio ads with people, older people still listen to radio, and so it was very effective. We're getting a lot of patients from that. We did sponsored content online in our local newspaper. I've met with many PCPs, podiatrists, orthopedics, rheum. I put nephro in there. Why would we call a nephrologist? Well, their patients can't take NSAIDs. And so they're excellent people to talk to, and they might send you a few patients. It's happened for me. I've spoken at journal clubs, at medical staff meetings, at Rotary Club. This is very different. This is different than oncology. I mean, we're talking about an elective treatment that a lot of people don't know about. So you kind of have to do a lot on your own to get the word out. So open the floor for questions. Okay, what's the average reimbursement for a hand or knee? It's all in, it's about $2,500, and about 500 of that is professional. The question was, sorry, what is average reimbursement for hand or knee? Like all the sites are the same. You're going to treat 6 fractions of a joint. You're going to put that arthritis M code, and you're going to bill for isodose complex. And I'm serious about that because we don't want to be doing 3D. Okay, do you add blocks to the fields? I don't do any blocks for hands. I sometimes do blocks for other sites based on the joint shape. But open fields are fine. It's easy. Like for the feet, it's open fields. I don't want to miss. And so there's not a fixed way to do it, but I think that's easy. And I think it makes a lot of sense to do it. The knees, I'll just um put little ones on the lateral aspect so that to not unnecessarily treat the lymphatics. Not that at 3 grade 6 frictions is going to cause lymphedema. Do you discuss second malignancy risk at all? I do. Radiation. I tell them that I tell every patient all radiation is associated with second malignancy. I tell them that there's no documented case in the literature of developing secondary malignancy from this treatment. But if it scares them, I don't want them to be scared, and they don't need this treatment because this is elective. So pain response. So this is interesting because this is new and there's no guideline. There's some guidelines out there, but we made our own pain form. We're tracking all our patients. We track them prior to treatment, on the last day of treatment, 2 weeks after, 3 months after, and then every 3 months. And then we convert it to telemedicine. It's not even a doctor visit. I just want to know what their pain scores are just so I can track it. The length of the effect is going to be variable. I break it down this way. I say 1/3 of you are going to get no benefit, 1/3 of you are going to get pretty good benefit, and 1/3 of you are going to get an excellent, durable benefit from treatment. Very different. Shiv asked about secondary malignancy. Again, there's nothing noted in the literature. This dose is super low, but I do warn them that all radiation is associated with secondary malignancy. Ankle pain. So I've had some success, and again, what we're seeing with our data is that every site is about the same. It's about a 2/3 response rate. So when do they normally experience pain relief? Some people midway through, and that to me is probably placebo. A lot of people at the end of treatment. A few patients until the 2-month follow-up, they don't have any benefit. And I'll see them a 2-month follow-up and they're like, oh my gosh, it's gone, and that happens once in a while. Rate of re-irradiation, about 50%. I think about 50% is what I've been doing. Everybody gets it. I do 2 courses total in 1 year. I've not done more than that. I usually wait 2 to 3 months for the first treatment. So the literature for steroid injection, someone's asking any benefit seen in combining with steroid injections. The literature for steroid injections is not good. And if anyone gets a fuss for doing what we're doing, the steroid injection benefit is not well documented in the literature. If you look at the Cochrane analysis, it's not it's that effective really. I wouldn't say not to do. It's just not necessarily. Do you sim retreatments? No, I don't. For reirradiation, I use the same dose. I have, okay, for inflammatory disease, at the beginning, we weren't doing it, but our kind of collaborative group, we talked about it, and we felt very comfortable with giving it a try. We thought, all right, if it is inflammatory, maybe this even makes more sense for them. I've had two patients so far. One works at my hospital, and she tells everybody she knows that Dr. Parikh saved her, and one patient got no benefit at all. Home run therapy, joint pains. That's awesome. I talked to my endocrine therapy patients about it. I have not found one yet to take. I have a friend that says he has remarkable relief in these patients. I would offer it. For the shoulders, pretty simple. Like we don't do some that questions are you using a long mask for the shoulders? And I don't. We don't use a long um, um we try to keep it as simple as possible. Uh any data for RA that's limited. No, there's not much data.
Okay, I think that was all of the questions. That was a lot of great questions. Thank you so much to the audience for asking those. Thank you to Dr. Parikh for the excellent presentation. Very, very useful. I think let's move on then to case number 2, and this will be presented by Dr. Flickinger from the University of Pittsburgh. And I see that Dr. Flickinger is logged on now. Hi, Dr. Flickinger. Do you just want to take a minute maybe to introduce yourself and then we can get started?
Unmute. Okay, I'm unmuted. Can you hear me okay now?
Yes, we can hear you now.
Yeah, my camera on my computer here in my office died out, and I had it fixed once, and it's still not, and promptly stopped working again. So I could try logging on with my cell phone, which doesn't have much battery life back yet, but I thought it's just better to go with. I'm much better looking on what you can see right now than in person anyway. So can you guys see my screen then? Okay.
Yeah, so yeah, I'm sharing the slides, so I'll be kind of clicking through the slides, and it's okay that we can't see you. We can hear you really well. So
Okay, that's great. So this is the this just an interesting case of keloids. So what was your last talk? I just logged on. Was Simil talking about?
he was talking about osteoarthritis and plantar fasciitis.
Yeah, sorry I was tied up with a patient. I really wanted to hear his talk. But anyway, well, plantar fasciitis is different from this. So this is this was very unusual case. I've treated a lot of keloids, but I think this one was much more memorable. So 75-year-old woman, she had a trigger thumb. So she had a thumb flexion release 10 years ago. And it developed a keloid after that. And then I think several years later, the orthopedic hand surgeon tried to fix that, cut out the keloid and did like a Z-plasty to try to fix the problem, and the keloid grew right back. And when I saw her, she was usually she was having a lot of pain. You try to move her thumb and her and she would cry with pains, which is very unusual. Usually with keloids, they cause itching And sometimes they're a little tender, but this one was a big problem. So so she really couldn't use her dominant right hand, and so her orthopedic surgeon sent her to who was a hand surgeon specialist, sent her to the plastic surgeon who for help, and then he called me. So she had tried steroid injections and really needed some help there. So I guess we have a poll up now. So what are treatment options? Surgery alone, radiation alone, surgical excision followed by radiotherapy. I guess all the above. You can't do alone as all above, but that's kind of included. So uh, uh, we're, because the audience is radiation oncologists, it's kind of skewed towards surgical, away from surgery alone. So everybody wants to, pretty much everybody uses the radiation, but when one vote for surgical excision alone. And yeah, this is a lot to tackle, so I can understand that. So if you're going to do radiation, how would you, the questions that we'll talk about is how how soon after surgery do you do the radiation? And we're used to treating people 3, 4, 5 weeks post-op for most, because we don't want to interfere with wound healing. And so there's several different fractionation schemes that have been used for post-op radiotherapy, and it's also, how do you simulate the patient when you can't bend her hand like that? So I guess we can move on to the next slide. Here's another photo of the treatment. So they, I mean, this was a big mess, and so a lot of skin to excise. So in this case, the plastic surgeon wanted to rotate a flap up from her arm, and so can you go back to that the prior slide? Or, so that's basically I think this was. He sent me some photos of another case that he had done like this, the plastic surgeon, where I got the idea that was the size that I needed to do. And I because you can't stretch the thumb out, I superimposed that on the other patient. I mean, on the other hand, so I just flipped it over as a comparison, but we are treating the right thumb in this patient. So that's the size of the scan. But as you can see, that you can't stretch out for pre-op simulation. You can't stretch out her thumb because she would cry out in pain. So I planned that ahead of time. So at the time we treated her, we had been trying to treat the same day. So, the problem with, obviously in terms of timing for treating keloids, well, you can't wait 2 or 3 weeks because the keloid may have already grown back. So the problem with keloids is, overzealous healing that doesn't stop. And so as soon as you have a surgical incision, the healing process is an inflammatory process that starts right away after the surgery. And the goal is to get it started within a short time of surgery. I think most people try to do it within 24 hours. For many years, we've been doing it here and with the same day of surgery, schedule the surgery in the morning and deliver the first treatment in the afternoon, the day of surgery, if possible. And then if there's any problems, you can at least do it the next day. And we haven't had in the past many problems, but still made sure not to schedule patients for surgery on a Friday so that we'd at least have a backup day. But since then, since we treated this patient, we replaced our treatment machine with a newer TrueBeam, and the setup so we're doing the treatments on a Trilogy, and it was very flexible, and I could make a guess before the surgery of what I was going to treat, and then adjust it, modify the cutout if I needed to, change the angle of the gantry. And once we switched to the new machines, it became very inflexible. And the first two patients was taking hours to get it done at the end of the day. And physics was crying that they're being rushed and they're going to make mistakes. And so we moved on to treating just doing the planning the same day as the surgery and treating the very next day. So this patient, this is the post-op film and pictures of this setup. So for electron setups, physics wants everything to be flat. So you want an even dose, and you want your at least the beam that where you're treating, it needs to be flat. So you end up adjusting the table and the gantry to make sure and the patient to make sure whatever you're treating is flat. And my guess for what we are going to be treating in this patient that I prepared prior to the surgery actually fit perfectly. So the plastic surgeon, because of her terrible keloid, wanted the entire incision radiated because he was afraid everything was going to turn into a terrible keloid, especially from the looks of the keloid that she did have. I am in the middle of a webinar. Can this wait? I can't see them. Or I can see them in half an hour if they can wait. Okay, thanks. Sorry. Sorry, it was a call for a patient on treatment, but I'm not going to leave you guys for that. Somebody else could see it. So anyway, so this was the setup for the picture. What do we have for the next slide? Let's see. So, what electron energy would you use? And do you use bolus? So were people going to vote on that, or we just do that as a rhetorical question? I guess a rhetorical question. But so if you look at these dose distributions for that's shown there, the low energy 6 MeV, you're not going to get to full dose unless you, I mean, to be on 95%, to get up to 95%, you need 8 millimeters or 9 millimeters there. So we're going to be using 1 cm bolus if you're going to be using 6 MeV, because this, and most of the time with keloids, we can treat with 6 MeV electrons. And all you need to treat is 5-7 millimeters depth. So that you just add on to your bolus and look at, so if you're using a centimeter bolus, we're going to look at 1.7, and you see we're at 90%. So 6-7 cm, or 6 millimeters about what you can treat here. Now it varies on different machines and also with different cutout sizes. So smaller cutouts, you're gonna have less depth dose. It's gonna fall off more rapidly. And 9 MeV for this one, if we go to 9 MeV, we're gonna, to get to 95, we get 2.6 or 2.5 centimeters. So minus the centimeter of bolus, you're gonna be able to treat to 1.5 centimeters to full dose. And you're only, at the surface about, with the 1 centimeter bolus, 92%, but you're pretty close. So electron rule of thumb, most people, it does vary with machines and cutouts. The range is about half. Most people say about a third to the 90%. But if you want to be sure you're covering everything to 95%, then a quarter of the energy. So if you say 9 MeV, a quarter of that is about 2.2 cm or 2.3 cm, and it's probably about 2.3 cm, which means with the bolus you can treat 1.3, 1.5. So one quarter for the range is kind of an overestimate, and a third is kind of too far. So you could divide it by 3, divide it by 4, and then average your answer, and that's really what your practical range is. So just a couple months ago, this patient came back because I treated her a little over a year ago. When she came in for her first follow-up, she was fine. She's has no restrictions in her arms, has no, full range of motion of her thumb, feels fine. So from the picture, it looks like that skin flap has a terrible radiation injury reaction, but in terms of hyperpigmentation, but that's not the whole story. There's a little bit of hyperpigmentation, but she has the skin that's pigment. I mean, if you notice, her palms are not heavily pigmented. This was rotated from a pigmented area, and I think we made it a little bit darker with the radiation, which accentuates it even more. But that's why it's not the reason why it's not as cosmetically appealing as if we had treated a light-skinned individual and rotated a flap up there. There'd still be some increased pigmentation, and with time that'll fade too. But with her, because it's pigmented skin, it's not going to fade back to the same color as the rest of her palm. There's just a few other examples of keloids. The most common one that we see is keloids from ear piercings, and So a lot of times, so it's an incision that, I mean, it's stimulated just from surgery, tends to happen more with infections, and people's earrings can sometimes, putting stuff in there, if they're not cleaning it all the time, they can get an infection there that helps stimulate the keloid formation.
Dr. Flickinger, I'm sorry to interrupt you, but we have just about a little less than 20 minutes left in the hour, and we still have Dr. Schuster's presentation at the very end.
Oh,
So would it be all right if I kind of showed your slides, and these will be posted? Dr. Flickinger has some really good slides with a little bit of data and things like
yeah.
that.
No, thanks for
So
speeding me up. I don't want to hog all the time. So, basically, we can just, if you can just roll through very quickly, but the keloids, radiation does work, but the literature for this is very confusing. I think when I did a review and a calculation of the alpha beta, there are a lot of large, I used a lot of large studies, but your results vary with surgical technique, with how many recurrences they've had, and with, so that, that can be affected by immobilization dressings, whether they inject steroids into the lesion, and so that and whether or not the site is under tension. So the earlobes should have the best results, and an earlobe keloid has only if you just excise it without radiation the first time, you still have a very good chance of it not recurring with a good surgeon. And but the other sites have much higher rates of recurrence. And if an earlobe keloid has recurred after it's been excised, then it's at very high risk. So I put in a lot of data, but there's problems with that. Dumping in data from multiple sources, and it looked like the alpha beta ratio came out to be like 2.5. So there was no advantage in extensive fractionation. Also, you want to treat quickly because the inflammation that leads to right after surgery, there's only a short time where the cells are driving to grow quickly. And if you wait too long to give the radiation, you're going to lose your window for stopping the keloid. Radiation alone doesn't make keloids resolve. Okay. We move on to the next case.
yeah, thank you so much, Dr. Flickinger. That was a great presentation, great case presentation. And thanks also for all that data. All those slides will be, posted online when this video goes. So that'll be a good resource for residents and students. So thank you so much. Let's move on then to our final case presented by Dr. Schuster.
Excellent. Yes, similar to Dr. Flickinger, I have few too many slides, few too much data, so we'll kind of hit the highlights off of each slide. But fibromatosis, it's fairly common benign disease, particularly Caucasians, a little more common in men than women, and of European descent. So my case is a 59-year-old female with nodules and cords of the hand and foot, and these are kind of what her clinical picture looked like. Then for our next piece, very commonly in my practice, these patients are self-referred, but theoretically they could come from hand surgeons, primary care. There is a Dupuytren's.org, and there are a couple of Facebook groups that are particularly active. And when I was training at VCU, that is one of the main ways that patients came, and this is how this patient came. So radiation is effective for prevention of disease progression in early stages. When there are small nodules and cords are present and less than moderate extension defect. So if you think about your hand and how far you're able to pull the finger down, these patients have curvature of the fingers. And so what you're looking at here is an MR. The arrows are pointing to 2 nodules. So they're fairly superficial. Typically the workup is a clinical workup. And so they come, a lot of these times they have so much less medical history. My consult notes look kind of short because there's not a lot else on there. But you can see this can be very complex. And it's kind of our job and the patient's job to help identify where the different cords and nodules are located. And so the image is an anatomy image, and you can see that there's the potential for cords in lots of different places. The lateral and medial part of the finger, the thenar cord. Most commonly, we see them in the 4th and 5th digit. And one of the, I think the, most common things that I get asked about is kind of how are we going to set this hand up? And there's definitely a variety of ways, but typically for the patient, a palpable nodule plus at least 10 millimeters. There's some dosimetric literature out there. This was a nice one that had a lot of photos. Meredith et al. In Journal of Clinical Radiation Oncology in 2007. And this is how I most commonly do it, is with bolus and with electrons. A lot of the initial literature was based on orthovoltage, but you can see that second picture there, when you have the bolus on, you're able to pull the dose a little bit more superficial. And most commonly I use 6 MeV or 9 MeV. For our particular patient, I used, there's a couple different regimens that are in use. Most commonly, if you don't mind going back one more, there you go. Use 30 gray in 10 fractions. You get 5 fractions, so a total of 15 gray, and then a 12-week break, and then an additional 15 fractions. And then for this particular patient, she was standing next to the treatment table, and her hand was laying on the treatment table with the electrons. Prone, I find either with a Vaclock bag or a foot sponge is a really nice way to kind of eliminate as much as possible the obliquity for our electrons. This is a very, very thin lady. So I put that lots of caveats on this 6 MeV with 1 cm bolus and 85%. That really doesn't give you very much. More commonly using 1 cm to the 80 or just making sure that you've looked at your depth dose curves to identify the right target, and then 9 MeV with 5 millimeter bolus to the 85% for the bilateral feet. This is kind of the, like, what do we think is happening? So you can see as you kind of peel back the layers of the hand, you've got the skin, the fat, and then there's the cords. And similar in the foot with the plantar fasciitis, these tend to be superficial to that. Originally kind of discussed in 1834, so it's been around a long time. And we don't know completely the genetics. There has been some work. We think that radiation is effective because you have a hyperproliferation of the myofibroblasts. And they're converting in production of collagen. And in later stages of the disease, we think that it's transitioned to a acellular collagen type 3 process. And that's why it's not as effective. Like once it starts contracting, we can't seem to slow that process. Good. There actually is a staging system. This helps identify patients that we think will probably have the most help based on the literature. So stage in is normal mobility of the hand with just nodules and cords. Literature suggests that just nodules progress over 20 years, about 35% of the time. If you have nodules and cords, the progression rate with no intervention is about 50% at 5 years. So there's certainly some patients who I counsel, they come in, they say, I have a nodule, I know it's Dupuytren's, please treat it. And I say, let's just watch it, because not everybody's going to progress. Then we have the most common treatments, like if they go see a hand surgeon or these kind of things, then they are oftentimes not getting recommended for radiation therapy. Needle aponeurosis, collagenase injections, or limited fasciotomy are more common. But you're like, what? This is a radiation talk? So part of it is that when you kind of do a literature review, we don't have a lot of interaction between hand orthopedic surgeons and ourselves. And some of their literature basically shows that there aren't any preventative treatments. And in fact, they have a meta-analysis that concluded radiation wasn't. So, there's definitely an opportunity to provide and share some of our data with them. In Germany, they have been kind of leaps and bounds ahead of us in using it in benign indications, hitting some of the discussions that we had today. This is a Delphi consensus from their benign disease group. You can see Dupuytren's gave a B rating, shall perform. Lederhose is a C, but I'll tell you that that's going to probably update because there was a randomized trial in 2023. And then Peroni's, which is basically the same process of the penis. And then for our plantar fasciitis, it actually gets an A, but it includes kind of a really nice evaluation for a lot of different benign conditions on that reference, Dr. Ziegensmit. I know I didn't pronounce his name quite right, but he is definitely on lots of the literature. So he had kind of the first randomized data, took a control group and also did two dose groups, a 30 gray with the split course and a 21 gray. And basically kind of what this is showing is that even with treatment, you get progression in those more advanced stages. So the more contracture is, the more likely they are just to progress despite treatment. The folks that had stage in, none of those patients progressed at 12 months. And in is just nodules. So this is that long-term data of that same population. So in the control group, any progression was 60%, and they offered surgery 30% of the time. So assuming that radiation is effective, then those progression rates should be lower. And that's what they demonstrated. So in the 21 gray group, 24% had progression. And in the 30 gray group, about 20% had progression. And you could argue that, you prevented quite a few people from needing a surgery down the road. And we know, at least from my experience, surgeons will tell people, we will not see you until you look like this and you can't get your hand in your glove. And so really giving them an option before that stage, I think makes this worth it. Things that demonstrated increased risk for progression, folks that are smokers. Not that we need more reasons as oncologists to tell people not to smoke, but one more. And then symptoms greater than 2 years. And stage with more extension deficit and involvement of the digits. I too have found that cords in the digits seem to be slightly less effective in the treatment than in the palmar area. Good, this is that dose variation. You can go ahead and skip to the next one. And basically what they concluded was there was no real difference in treatment outcomes. Dr. Ziegensmit thought on that 2015 publication kind of concluded the best clinical outcomes were reported with 30 gray, which was applied in 2 separate radiation series of 5 × 3 gray with an interval of 12 weeks. I have stuck with that, but really the main difference in this randomized study between 30 gray in the split course or 21 gray in the straight course was this main difference was an acuter toxicity. So some grade 1 and 2 skin toxicity. And then numerically, the numbers were a little bit better with regression and stable disease, but not statistically significant. Good. We do have really long follow-up. Looked at about 120 cases. And I think this is the numbers that I quote people. I usually say at around 10 years, if we have treated this in the early stage, about 70% of folks that have minimal extension deficit are stable or have even regressed. The folks that are just nodules, they have around 90% in this paper. However, I struggle with that number a little bit because there's probably some of those patients that got treated that may never have progressed. Excellent. So this is just demonstrating kind of what they saw over kind of their time course. So we can skip that one just for the sake of time. And, kind of the late toxicities reported in this 13-year outcome, thankfully, really dry skin, a little bit of desquamation, skin atrophy, occasional telangiectasias, and erythema. There were no chronic grade 3 or 4. And it's nice to have this data to lean on to say that there also were no reported secondary malignancies in the setting of treating fibromatosis. Great. This is a study that came out of VCU, where we retrospectively called patients who we had provided treatment for. The vast majority of patients were that 30 gray and the split course. Patients can have itching, grip, tension, pressure, pain relief, and kind of what you're representing here is that over a 5-year period, the vast majority experienced relief in those symptoms of itch, pain, and skin changes. Again, this is kind of just what those things look like. We did kind of try to distinguish whether we had an in-field versus out-of-field progression. And in our series, what we found at that kind of a 5-year mark is that we were kind of right on target with about 80% of folks that had stable disease. Why don't we do this in the US? I think there's kind of a little bit of an over fear of secondary malignancy. And we can see, we probably all have our own little spiel about how we define that for patients. But, I have something very similar to Dr. Parikh. I say, radiation certainly carries a little bit of risk, but it's never been documented in literature for this type of treatment. There we go. Oh, somehow that one got in there twice. There we go. Keep going. One more. I want to make sure. Oh, one more. There we go. So this is a really fun study published in 2023 for Lederhosen, and it was a prospective, multi-center, randomized, double-blind phase 3 sham versus radiation. And pain reduction was the thing. So they looked at 84 patients. They basically brought all patients in. They laid them down on the treatment machine, moved the machine, and half of them got radiation and half of them didn't. And so at 12 months, the clear winner was our radiation arm. And they had kind of a very specific pain scoring system. Pain relief was 74% versus 56% versus the sham. So a little like Dr. Parikh's talk about osteoarthritis, whether we healed with the healing beams officially or healed with the placebo beams, they did seem to get better. And then higher quality of life, though. So it does seem that radiation really has an effect beyond the placebo. Higher quality of life, higher mean walking speed and rate of step with barefoot walking, very minimal side effects. And this group did use the standard, 30 gray in 10 fractions with that 10 to 12 week split. Excellent. I think that last one should be a little summary. So summary, I think of this in a couple of ways. Is this likely to actually help? Meaning the patient needs to be have some nodules and cords. Is this likely to actually benefit them? And that is, are they early enough where the radiation is likely going to be effective? And then how much toxicity do I think there might be? I'm a little more cautious for younger patients and a little more avid to treat patients that are a little bit older and have said, hey, I've noticed this change in the last kind of 6 months. And then typically, again, there's not necessarily an absolute perfect way. I didn't have a chance to go into the literature. There's a little literature for IMRT, but I standardly use a clinical setup with a CT and use 30 gray in 10 fractions with that 15 or that 12-week break. And that's based on the consensus, even though the Ziegenschmidt data, some of that was shorter, 6 to 8 weeks, because he's on the guideline and it now kind of says their consensus is 12. I have adopted 12. and then use electrons and use my depth dose curves. I typically get either an MRI or a CT sim to establish the depth of those nodules, particularly in the feet, because I think it's a little harder to feel like you're really palpating the full depth of the nodule or the cord. And then typically use at least 3 to 5, but you could see vast majority of the kind of treatment outlines you saw there were at least a centimeter away from any nodules or cords. So that was a speed version. I included a lot of extra slides at the back just for reference that go into a little bit more detail of the other types of treatments and the comparison between orthovoltage.
Yeah, thank you so much, Dr. Schuster. That was great. And I'm really impressed with how many slides you got through in that short amount of time. But thank you. Thank you so much to all of our panelists. I think this was a really educational session. I certainly learned a lot. And thank you so much to our guests, our audience that logged on. If it's okay, Dr. Schuster, do you mind answering just maybe one question? It looks like there's a question in the chat. Is brachytherapy used for treatment of fibromatosis? Any comparative studies with electron therapy?
Oh, I don't know of any comparative studies. However, your superficial brachy certainly potentially has a role. I know Dr. Devlin, he has looked at a lot of superficial brachy, like skin brachy. The only piece, I think on the foot, it's probably too deep unless you actually put the catheters in. But on a hand, like my patient with the very thin, small hands, the dosimetry might have been very good. Because, but I personally have only done a little skin brachy, so it'd be hard to kind of estimate. But there are several, like I said, there's an IMRT study. There is there's a group that has done protons. So, and if somebody did it, I bet it was Dr. Devlin.
Okay, thank you so much. To our participants, thank you again for your time and participation. Please be sure to fill out the post survey. It really helps us to kind of understand what these sessions are providing and help to make them a little bit better. We always hope to improve. If you find these helpful, we have 3 more sessions coming up this academic year. The next one is going to be January 5th. It's scheduled at 12 p.m. PST, 3 p.m. EST. It's going to be on CNS modalities. So if you're interested, you can sign up for this through our website at radoncvirtual.com. Thank you so much, everyone. Hope you have a wonderful weekend.
Great, thank you so much.
Yeah, thank you. I think for people that are still listening, that the slide for the radiation of the foot, you have to warn patients that when they get the sole of their foot irradiated, that they can sometimes lose their callus and the foot can get very tender. So that, I mean, there's only a few conditions when we need to do that, but sometimes patients will be very, very unhappy about that, of how tender their feet are. And so if you don't warn them ahead of time, they'll be mad at you. I had a patient that had with Kaposi's have their entire foot radiated in